Good morning. I hope everyone slept well after a great program last night. I am very pleased to welcome everyone to day 2 of our conference and welcome our viewers from across Canada at home. I'm very pleased to introduce our next speaker, Dr. Vivien Brown, and a really important topic because she's going to be talking to us about respiratory vaccines. And Dr. Brown has been a champion of vaccine education for a really long time. She is a family physician in the Toronto area and recently won the Physician of the Year of the region for the region of Toronto, which was pretty exciting. And she's the author of The New Woman's Guide to Healthy Aging. This is a really important topic when we want to keep saying COVID is over, and she's going to talk about COVID. Yesterday, about an hour before the conference, I received notice that my uncle died of COVID in Nova Scotia. Ironic when I'm here. And he's in a long-term care facility, and still this far in, we're not doing enough to protect our residents in long-term care facilities. And people don't want to have hard conversations about COVID vaccines because it's tough and people get angry. But if we don't protect younger people without immunity, we're going to keep infecting people like my uncle. And now I've just one uncle left on my dad's side of the family. And the work that we do is really important. And we're going to listen to Dr. Brown right now. And she's going to help us have those hard conversations. Thanks.
Sorry for your loss. So good morning, everybody, and thank you for getting up early and coming here. And what we're going to talk about is the bottom line, respiratory infections. What do you really need to know? What's important and how are you going to act on it? In terms of disclosures, I'm happy to say that I work for all the vaccine companies, and this presentation is mine. I'll take all the credit, but I'll also take all the blame. I think it's really important to know what is guideline driven and what is personal opinion. And so when we go through this, I'll tell you where there are guidelines and what guidelines we're following and where there's no guidelines yet. So the learning objectives for this morning are to identify the high-risk groups that may lead patients to experience poor outcomes from respiratory illness, including older age, immune status, and comorbidities. And Cheryl just shared a heartbreaking story of someone that fits in that category. We want to understand the latest guidelines or expert opinions on the newest vaccines and select appropriate fall vaccination strategies based on NACI guidelines and supporting clinical evidence. So let's get it out of the way. Let's talk about COVID. Patients say to me, I am so done with that. I am so done with COVID. And my answer is yes, but COVID is not done with you. COVID is an infection that's going to be here on an ongoing basis, and we need to accept that fact. And some of the times when we look at vaccine fatigue, we as providers are getting tired, and certainly the public is getting tired. And we really want to guard against that, because if we let down our guard, we see more disease. And so right now, this is epidemiology from September of this year. We see a number of total cases, and that's an underestimate because people have stopped testing at home. And we see total deaths, and deaths keep going up. And what we know is as we're getting into this season, the deaths and hospitalizations are greatest in people over the age of 65 and people with underlying illness. And that's what you can see by this epidemiology review. As you get older, you're more at risk for hospitalization, and if you're hospitalized, you're more at risk for death. So you can see why someone in their 20s or 30s says, you know, like, why should I care? And part of why you care is because you care about your family, you care about your community, you care about the very young that cannot be immunized for various reasons, you care about people who are immunosuppressed. And I think it's really important that we talk about community when we're talking about COVID vaccine, not just about the individual. And it's a good time of year to do that because everybody's starting to think about Christmas holidays and getting together and who's going to be sitting around that table and who is at risk. So when we see the hospitalization rate, It's over 70% in older people. This is over the age of 60. That's not that old. And death rate is 90% of the deaths are over the age of 60. So this is a slide that I'm showing you, which are the risk factors for COVID-19, but I'm going to show you a similar slide for influenza. I'm going to show you a similar slide for pneumonia, because these diseases all go hand in hand. So for COVID-19, there's biological issues in terms of age and obesity, but also pregnancy, disabilities. We know that behavioral things can affect your risk of COVID, whether you smoke or not. This audience knows about smoking. I'm not going to dwell on it, but when you ask individuals in a practice, do you smoke? I sometimes hear, just occasionally, if I go out with the girls like Saturday night, or I hear, I don't smoke cigarettes, but I do marijuana 3 times a day. You know, so let's think about smoking and inhalation and the risks thereof. There's medical things like cancer and chronic kidney disease, liver disease, diabetes. Diabetes comes up again and again and again as a risk factor. Think of it as an immunomodulating disease. It's not just about sugar, it affects your immune system as well. And because of that, it's a risk in influenza, and it's a risk in pneumococcal disease. So what did NACI say in the spring? In the spring, NACI suggested that people may be offered a dose depending on their age, and we focused on the over 80s. We wanted to get the people most at risk, as well as those in long-term care and congregate living situations, those with immunocompromised, who were immunocompromised, and adults aged 65 to 79, particularly if they hadn't had COVID already. Well, NACI came out with newer guidelines in the fall, and NACI says that if you've been previously immunized, you should be immunized with a new vaccine if it's more than 6 months since you've either had the vaccine or since you've had the infection. And now we're looking at adults 65 and older, not 80 and older, as well as residents in long-term care and other congregate living situations. Particularly important, those people are suffering with immunosenescence. Their immune system is weaker. And when I talk to patients, what I say is 65 is not that old, but just the way you wear glasses because your vision is getting a little bit older, or maybe you've got a hearing aid because your hearing has deteriorated, your immune system is not as robust as it was when you were 20. And one of the best examples of that is that's why we give a higher dose influenza vaccine to people over the age of 65, one of the enhanced vaccines, either adjuvanted or high-dose Fluzone. And if we give you a greater boost, you'll get a greater response. So we absolutely want to be immunizing and talking about immunization for COVID to all these people at this age, as well as people who are pregnant, people who are from First Nations, Métis, and Inuit communities, and other racialized and other equity-deserving communities. A number of ethnic communities in different provinces are just very low on immunization. Well, this is one of my favorite slides, and what it shows is that when you're older, you have a higher risk of long COVID. And if people are not anxious to take the vaccine because they're not worried about getting a mild flu-like illness at home for a couple of days, remind them that 1 in 5 people of an older age will get long COVID with those symptoms that affects your smell, taste, your activity level, your energy level, all of those symptoms that are hard to measure and that don't go away very quickly. We also know that vaccination reduces that risk. And while we're not vaccinating to prevent long COVID, it's one of the benefits that we get. And so this slide just shows you that there was less disease when you were already vaccinated. And this is most important in people who are most at risk. So what do we do for COVID? Well, we've got treatment, and it's different rules in different provinces. So I'm not going to attempt to go through each province and say what the rules are. But basically, we have one oral product, nirmatrelvir ritonavir, and it's a tablet called Paxlovid, and you're probably familiar with this. And Paxlovid is given for 5 days within 5 days of the onset of a positive COVID test. In research, it shows that by using Paxlovid, and I'm going to use that name because it's just so much easier, but it shows that it reduces the risk of hospitalizations and mortality. So this is really important when you're seeing people at risk. What you want them to do is you want them to be identified if they have COVID quickly so that they could be on a medication to reduce their risk of hospitalization. And this just goes on to show that they're further from the study. It was a Canadian study published in CMAJ. And this goes on to show you the decrease in hospitalization and the decrease in death compared to untreated patients. Well, this is a population-based evaluation of its effectiveness. And why I like this is because if you were older than 70 or younger than 70, if you were vaccinated or if you were not vaccinated, if you had your last vaccine recently or your last vaccine more than 6 months ago, if you had comorbidities or if you didn't have comorbidities, all across the board, Paxlovid worked. And I think that's important because we sometimes don't have the time and don't necessarily have the expertise to pinpoint who is going to be the best person to give this to. This suggested that giving it broadly really made a difference because you can see by the forest plot that everything landed up on the positive side. It was worth it to give the vaccine, to give the medication, even if you weren't vaccinated, even if you were under 70, even if you had no comorbidities. So I practice in Toronto, and in general, I'm using this relatively liberally in my older population and certainly in the population with comorbidities. And this just shows you, this is a Korean study, and it shows you the effect of Paxlovid in nursing home settings, where basically it decreased the risk of severe illness or death. And that's what it's all about. So how do we use this drug? Well, the Ministry of Health in Ontario came out with guidelines and basically said we should be prepared ahead of time. Now, I don't know how many of you work in nursing homes. I don't know how many of you take care of chronically ill patients. But in order to use the drug, you need a clinical assessment, you need renal status. So you need to do that blood test for creatinine, and you need to have an idea of what other medications a patient is on, as well as the goals of care. If someone is palliative, you're not going to jump to use this medication. But if someone is reasonably healthy and they're in a long-term care, retirement home, or other congregate living situation, you want to be ready, just the way you're ready to use Tamiflu with influenza, to use this drug if you need it. And so the ministry in Ontario came out with a guideline that said, get ready now. This was in June, right? COVID was not on the rise at that particular point. But by getting ready, by knowing ahead of time who we're going to treat and how we're going to treat, makes a huge difference. And they encouraged healthcare providers to be up to date, ready with their pharmacy. I don't know if there's any pharmacists in the audience, but for the pharmacists to have done that drug review to see that they're on drugs that are compatible with Paxlovid, because there are a number of drugs that are not. So that's my discussion of COVID. And I just want to tell you that when I see patients in my office, I talk about vaccine with every patient every day, no matter what they're in for. Because whatever they're in for, if they get COVID, if they get pneumococcal disease, if they get severe RSV, it's going to affect the rest of their life. So let's move on and talk about invasive pneumococcal disease. As you know, and this group is probably familiar with this, strep pneumonia is the major cause of human infection. And in adults, we see a very small number with meningitis, a very small number with bacteremia, and a huge number with community-acquired pneumonia, which may be invasive or non-invasive. So it's the community-acquired pneumonia people that we want to treat so they don't end up in hospital and they don't end up on a ventilator. Well, there's many risk factors, and think of the slide I just showed you with the risk factors for COVID. Here we go again. It's the immunocompetent people with diabetes, chronic heart disease, chronic lung disease, functional and anatomic asplenia, etc. It's also people who are immunocompromised if they've got autoimmune diseases. These are your young women with lupus or rheumatoid arthritis or psoriasis. If you watch US TV, you see psoriasis on the news every day in those ads for Stelara. You know, people on Skyrizi, Stelara, some of these immune modulating drugs are really important to recognize that although that patient may feel healthy and look healthy, they are immunocompromised and more at risk for these diseases. External factors such as preceding viral infections. 40% of pneumococcal pneumonia patients in hospital had a preceding flu or RSV. We know that smoking, alcohol abuse, living in a residence all have an impact, but age itself, age 65, increases your risk for community-acquired pneumonia and pneumococcal disease. Hospitalization is associated or can be associated with an increased risk of cardiovascular disease, so that when you look at a large proportion of hospitalized patients with a community-acquired pneumonia, 17% have cardiac complications, 14% have heart failure, 5% will get into an acute coronary syndrome, and about 4.7% will get arrhythmias. Inflammation of the lungs leads to inflammation of the heart. And it is a risk for heart disease if you are suffering from a community-acquired pneumonia. Similarly, there's research that shows you if you're immunized against pneumococcal disease, it decreases your risk of an MI over the next time period. Even if you had no history of heart failure, 12% developed heart failure, and patients admitted about 60% increase in short-term mortality. So hospitalization for pneumonia is a serious, serious illness. So what recommendations do we have in terms of pneumococcal pneumonia? I'm just showing you what NACI has said. And as a reminder, I know this group probably knows, but NACI is the National Advisory Committee on Immunization. NACI gives us our national guidelines that then get implemented 14 different ways in the provinces and territories. So NACI has given a strong recommendation, which means it should be offered to everybody over the age of 65. I'm now talking about PCV20. It should be offered if you're between 50 and 64 living with risk factors that put them at higher risk, and 18 to 49 if you've got immunocompromising conditions. So that is a very strong statement. That means if you're 65 and I haven't talked to you about PCV20, I am not doing my job. We know that we can use, and there's a discretionary recommendation for PCV15, followed by Pneumovax, followed by PPSV23, if PCV20 is unavailable or there's some kind of need for an alternative. But what I tell patients when I'm offering them PCV20 is I'm using the language from ACIP. ACIP is the American body that recommends to the CDC. And ACIP says with PCV20, you're one and done. You don't need a second pneumococcal vaccine. This is a conjugate vaccine. This is going to last a long time. So for pneumonia, unlike COVID, unlike flu, unlike RSV, but for pneumococcal disease, one and done when you take PCV20. Well, what if you've already had PCV13, or what if you've already had PPSV23? So what if you've had Prevnar 13 or Pneumovax? Well, NACI says if you've just had PCV13 and it's more than a year, take PCV20. You're missing those 7 serotypes that we want to get. And I remind patients that years ago, we had PCV7 for infants. Then it went to Synflorex, which was the equivalent of PCV10. Then it went to PCV13. So adding serotypes is what we've been doing for the last 25 years. If you've had Pneumovax alone or PCV13 and Pneumovax, it's possible to wait 5 years because you've got some protection from the Pneumovax for those first 5 years, but then the vaccine wears out and boosting doesn't help. I also would remind you that when you're looking at vaccine, you can't predict the future. You can't predict how ill somebody is going to be. And so if they're well, if they're healthy, if they're coming in to see you, if they're coping with their chronic disease, whatever chronic disease that is, a serious case of pneumococcal disease is going to destabilize that chronic disease. So you may not want to wait the 5 years that you're really given permission to, because there's no great benefit in waiting. Can you give this with other vaccines? And the answer simply is yes. There's some data with flu vaccine, and NACI tells us overall that we can co-administer multiple vaccines. What I tell patients is your arm is going to be sore. You may feel more fatigued as your immune system is getting boosted, but it's very safe. And look what we do to infants. We give them Pediasel. We give them 5 vaccines in one shot. We give them MMR, another 3 vaccines. So we're using multiple vaccines all the time. We just don't always realize it. So when we're looking at high-risk groups, absolutely we want to give these vaccines because it's important to protect people, and it's important that we do this to the best of our ability. So when we're looking at pneumococcal disease, let's remember we do have treatment for pneumococcal disease. It is a bacteria, but once you're hospitalized, it's not just your breathing that's compromised, it's your risk of cardiovascular disease, and it's your destabilization of your other diseases. So let's move on to RSV. It's sort of like the new kid on the block because we're discussing it, but RSV has been around for a long time. It's underestimated and underreported because in a community practice, if someone walks into my office and they've got fever and a cough and they feel unwell, there's no way to distinguish COVID from influenza, from RSV without doing PCR testing. And at least in Ontario, there's no testing done in the community. You only get tested if you go to hospital. So we underestimate and we call it a flu-like illness. And we don't know if it's flu or if it's RSV. Now we're doing the testing and self-testing for COVID, so we may be able to distinguish that. So, over the years, people have said, why bother with this flu vaccine? I got the flu anyway. Well, they maybe didn't get the flu. They maybe had RSV disease and they didn't know it. So there's an under-recognition of this disease because there's lack of routine screening and laboratory diagnosis. There's the perception that in adults, it's a mild disease, like why bother? And there's apathy towards diagnosis because we don't have effective treatment. And that's true, we don't have effective treatment. So RSV is thought as a pediatric illness. Most cases are under the age of 2, and that is absolutely true. But as you get older, you start to see cases in people over the age of 65. And I'm going to show you some data about hospitalization and mortality in just a minute. And here it is. If you're under the age of 5, 70% hospitalizations are in that age group. Only 8% are in the age group 5 to 64. So people in their healthy adult years don't get hospitalized with RSV. But about 22% of people over the age of 65 will account for the rest of the hospitalizations. But look what happens. Happily, we don't see a lot of deaths in children under the age of 5. The rates are approximately 1 in 1,000. So when children get admitted to hospital, they need oxygen, they need support, they need care, but the death rate is very low. It's 1 in 1,000. When that small number of adults get admitted to hospital, so admittedly only 22% of the hospitalizations were adults, unfortunately, they account for 85% of the deaths, and the death rate if you're hospitalized with RSV is 1 in 9. Now that is a scary number. And what I tell patients is it's my job to keep you in the community. It's my job to keep you as healthy as you can be, because once you're in hospital, other people take care of you. And unfortunately, the chances of you coming home and quote unquote being yourself again are relatively low. And that death rate of 1 in 9 is really high. So what are the complications? Why do people die of RSV? Well, this is what happens with influenza. About 48% of people hospitalized will have lower respiratory complications, right? They can't breathe. They get a bacterial superinfection about 38% of the time. They get cardiovascular complications about 1/4% of the time. And they get readmitted to the hospital 1 in 5 within 3 months. So they get sent home, but they're too sick and they get sick again and they're back in hospital. Well, that's influenza. We're familiar with influenza. Well, look at RSV. The numbers are higher for lower respiratory complications, numbers are higher for cardiac complications, and the numbers are higher for hospital readmission and death. So this is a bad combination. And often in hospital, someone can have RSV and influenza. It's not necessarily either or, it can be both. And remember, I just told you there's a 40% risk of going on to pneumococcal pneumonia. So very quickly, I'm going to tell you a little bit about the new RSV vaccine. Basically, there's two types or 2 antigens on RSV called RSV-A and RSV-B. And what we know is there's a protein called a fusion protein, and both of those antigens are part of the fusion protein. So if we're developing a vaccine, we want to get the vaccine that's going to cover both RSV-A and RSV-B. We're not going to pick and choose because different forms of RSV are prevalent in different years. Well, there used to be an RSV vaccine that they were trying to develop about 20 years ago, and it was a total failure. And why is the RSV vaccines that are coming out now so much more successful? And this is just the only biochemistry I'm going to show you because I think it's so elegant. Essentially, what you have is this doesn't work so far. Okay, what you have is a pre-fusion shape of the virus. And the pre-fusion shape has openings for the antibody to attach to. If the virus fuses, it closes up those openings where the antibody can attach. So if it's a post-fusion virus, the immunization is not going to work because it's like they've blocked the lock, the key can't fit in. In the pre-fusion shape, there's openings for keys in different places. So the brilliant researchers have figured out that if they can keep the virus from fusing and changing its shape, it's in a pre-fusion state, the key of that antibody is going to be able to get in. And that's exactly what the companies have done. So what we have is we've got the pre-fusion vaccine with all of these openings or locks so that the key of the antibody can fit in. And right now, the immunization on the market is a GSK product called Arexvy, and it is a recombinant pre-fusion subunit antigen with an adjuvant, and I'll talk about that in just a moment. What we're getting and what's already in the US is the Pfizer product. It is also a pre-fusion bivalent RSV vaccine. It does not have an adjuvant, but it also covers A and B. So these vaccines are both in the States right now. And to my understanding, what is recommended is to vaccinate people. ACIP has not given preference to one vaccine over the other. What's coming down the pipeline in the next year or so is an mRNA vaccine from Moderna, which is going to be based on how they did the COVID vaccines. And if you think of the mRNA platform, think of mRNA like your cell phone, and the different vaccine is like an app. So they've got an app that they've downloaded for their current COVID vaccine, and they're using the same mRNA platform and developing an app for RSV. So that's a little bit down the line. But these are the studies that have been presented to Health Canada. The GSK product, which is Arexvy, has been approved as of August of this past year. So that's the vaccine we currently have. The RSV pre-fusion protein vaccine from Pfizer has been presented to Health Canada. We don't have approval yet, but it is in the States, both for maternal use as well as for over 60. And the mRNA vaccine is a little bit behind. It's estimated to be complete in terms of their studies and presented in the next 6 to 12 months. So I just want to tell you a little bit about some of the information on these vaccines. The Renoir study was the study that was done on the Pfizer product. It had people with stable chronic conditions, but they didn't have perfectly healthy people. They had people like you would see in the community. It was randomized 1-to-1. There were various age groups, including people over the age of 80, and they were followed for 2 seasons. And Canada was one of the sites for this vaccine. And what they were able to show is they were able to show great efficacy of 67% in the RSV that was associated with 2 or more signs or symptoms of disease, and even better vaccine efficacy if people were sicker and had 3 or more signs of disease. So this looks like it's going to be an excellent vaccine, and we're expecting it. Not going to talk more about it because it's not here, but this study has been published, and I wanted to share it with you. The vaccine that is here is the GSK product, and the GSK product is an antigen and an adjuvant. And think about shingles vaccine, Shingrix. It's an antigen and an adjuvant. Well, this is the same adjuvant that's in shingles, but half the dose. When you get the vaccine, it's 2 little bottles, it's powder and liquid. You have to mix it and inject it just the way you did with Shingrix. And they saw excellent efficacy as well. It reduced risk by about 71% of acute infection. The primary endpoint was lower respiratory tract infection, and risk was reduced by about 82%. And for the most severe disease, the people we're most worried about, the risk was reduced by 94%. So we do not have guidelines in Canada yet. Let me be very clear. When something is approved with Health Canada, it doesn't go to NACI for 6 to 12 months, because NACI is not going to look at anything until it's already approved, and then it takes them time to review it. So NACI has not given us guidelines. Anything that I'm following in my practice today is based on ACIP guidelines, which are the American guidelines. And ACIP said that adults age 60 and older may receive a single dose using shared clinical decision-making. ACIP is very careful with their language. They didn't recommend the vaccine, because if they recommend it, every insurance company has to pay for it. So they said may receive. They were careful with the language. But look at the chronic underlying medical conditions associated with increased risk. It's the same group of people that I've already showed you who are at risk for COVID and who are at risk for pneumococcal disease. Kidney disorders, all these people with an EGFR lower than 60, that's considered chronic kidney disease. Excuse me, lung disease, cardiovascular disease, diabetes, etc. Frailty, living in a nursing home. These are the people that you're taking care of, and these are the people that are most at risk. Based on this information and based on how poorly people do in long-term care, Ontario made a big step forward. I'm a little bit cynical, so I think there was a lot of political maneuvering. But in Ontario, the RSV vaccine is being provided for free in long-term care, in congregate living situations and other seniors facilities. Now, my own opinion is we did so poorly in Ontario with COVID in long-term care that they felt they needed to do something, and so that's what they did. So it is covered for people who are most at risk, and I use that information to tell my patients that those are the people that are most frail, and we are covering them. You should be covered too, because again, my job is to be your doctor and keep you in the community. Once you're in long-term care, we're done. ACIP talked about clinical decision-making in terms of timing. And basically, you can co-administer this vaccine with other vaccines. So you can give it with flu. And the studies have not been done with COVID, pneumococcal vaccine, Tdap, or Shingrix. But in general, co-administration, according to NACI, is very safe. There's one caveat that I want to tell you about. And that caveat is you don't generally want to give 2 adjuvanted vaccines at the same time, because although it's safe to do it, it increases reactogenicity. And so if you're giving RSV, for example, which has an adjuvant, you don't also want to give Fluad, which has an adjuvant. It's better to give Fluzone high dose. If you're giving RSV, don't give Shingrix at the same time. Again, it's safe, but they're going to be pretty miserable the next day with a sore arm, low-grade fever, muscle aches and pains, and feel unwell for a day or 2. Now, I have some people that come in the office and say, give it to me, I need it, I don't have time to come back. That's fine, it's safe to co-administer, but you just want to be careful about 2 adjuvanted vaccines. And that's just what I've told you about here. The side effects are very similar to the shingles side effects. You know this, you're familiar with this. Shingrix has been around for a while, and it's very safe to use this vaccine. So let's go on and finish up talking about influenza, because I want to leave some time for questions. Influenza, we all know and love. It's the season again. Here we go. Well, this disease affects 5 to 15% of the population annually. That's a huge number. And what we know is influenza and pneumonia are in the top 10 leading causes of death. COVID is number 3 or 4. Heart disease is still number 1, and cancer is up there. And with influenza, we've got about 12,000 hospitalizations and about 3,500 deaths per year. This is preventable. We shouldn't be having these numbers year after year, and these numbers continue. We know that there's all kinds of risk for influenza, and I'm not going to go through these in detail, except to remind you that pregnant women are more at risk for influenza. Pregnant women should be immunized for influenza, immunized for COVID, and protecting their baby with pertussis immunization. And the cascade of influenza is just huge morbidity. So people say, yeah, I got the flu, but really what does it do? It gives you uncontrolled blood sugars and impaired complications of diabetes, sometimes serious impairment. If you've got neurologic complications, it can go on to lead to seizures, Guillain-Barré, and encephalopathy. And let me just remind you that Guillain-Barré with influenza vaccine is exceedingly rare. It's much more common with influenza disease than it is with influenza vaccine. If you've got inflammatory complications, you go on to cardiovascular complications. If you get dehydrated and have electrolyte imbalances, you get renal complications. You get deconditioning, you get weight loss, and you get less ability to do your daily activities. We've got wonderful vaccines from all different companies. We've got standard vaccine for everybody up until age 65, and then we've got enhanced vaccines. If the enhanced vaccines like Fluzone, high dose, and Fluad are not available, give someone standard, because give them anything is better than giving them nothing. However, if you have the ability or the product to give high dose vaccine, it's 4 times more the antigen than in standard dose. And in the US studies, it showed about a 20% reduction of hospitalization. So giving someone more of a boost, you'll get more of a response. I want to remind this audience, to remind everybody that you see, that there's non-pharmacologic preventions that work really well. And we saw that with COVID. We didn't see much influenza and RSV in 2021. It skyrocketed in 2022. Why did we not see it in 2021? Because we were socially distancing, we were avoiding crowded spaces, we were wearing face masks, we were frequently hand washing, we were educating our patients to stay home. When they were sick, patients needed to be aware of not exposing somebody else. And what we know is that these interventions help, but they don't replace influenza immunization. So I really want to encourage everybody to be aggressive in their talk about prevention. And the way I talk to patients, we talk about a presumptive message. Well, for me, a presumptive message is walking in the room with the flu shot in my hand and saying, which arm do you want it in? It's a given that I want to give them the flu shot. I don't want them to be a frequent flyer in my office. I don't want to see them again till next spring. And I think what we want to do when we're talking to our patients, particularly our older patients who truly value their independence and truly value living in the community and truly value the fact that they're very proud and they can take care of themselves. We want to tell them that it's our job to keep them there. It's our job to prevent them having to go to long-term care. It's our job to prevent the increasing frailty. And part of that job is normalizing this discussion on vaccine so that they're as up-to-date as they can be. And generally speaking, something like 80% of Canadians think they're up-to-date for vaccine. And when you actually do the research and you look at the numbers, it's about 3%. People think they're immunized and they're not. They don't know about RSV vaccine. They had pneumonia vaccine when they were 65 and they had Pneumovax and now they're 80. You know, they don't know what they don't know, and they need to know that their vaccines have to be up to date in order to protect them. This is the trajectory after hospitalization. And I have to tell you, I see this time and time and time again. They're hospitalized from some respiratory disease and they lose some weight in the hospital. They get readmitted within 30 days, 3 months, 6 months, but this time now they need oxygen. They're short of breath when they go for walks. They have less energy to exercise, so they're more sedentary. They're no longer able to do their prior enjoyable activities like golf, lawn bowling, gardening, playing with their grandchildren in the park, just having the energy to do something. They're short of breath. They have a loss of independence, a loss of confidence, and a significant impact on their quality of life. And their frailty increases. And what happens when we see these people? They are deconditioned, they're not active, they slip and fall, they break their hip, and the death rate from hip fractures in older women is 27% in the first year. Death rate for men is 37%. You know, so when we're thinking about respiratory disease, it's not just the disease, it's their quality of life that we're talking about. And I think that coming from you, amplifying the message that's coming from public health, amplifying the message that's coming from the pharmacy, amplifying the message that's coming from their own doctor, they end up choosing to take vaccine. So, in conclusion, I think we need to normalize the conversation about vaccine and disease prevention. We want each patient, each visit to be updated and reviewed before the onset of the fall respiratory diseases. An adult vaccine is an ongoing process of prevention and good health, stabilizing those with comorbid conditions and preventing increasing frailty. I was a big fan of Game of Thrones. I loved that. Made me stay up half the night after I saw it, but I loved that show. You'd hear this ominous music, and one of the characters would say, "Winter is coming." And everybody would know what that meant. This was bad news. Well, I want to leave you with a reminder. And, you know, it's beautiful here in Vancouver, but I want to remind you that winter is coming. Thank you so much. Yeah, thank you.
So if there are any questions, and I think, Aaron, we had a question.
So we do have a question
from our
from
virtual
online.
audience. Yeah.
So I'm going to read the question out loud. So this is not my specific words. So Andrea asks, would you recommend the Paxlovid for those with epilepsy? And then if so, would you suggest a 6-month booster?
So in general, I'm not expert on the drugs that interfere with Paxlovid. Before I could recommend it to somebody with epilepsy, I would have to review their medications and make sure it was safe. In general, I think it's a reasonable idea, but it depends on the medication. And I'm sorry, what was the second question?
This referring to asthma and COPD, how you would approach those.
Asthma and COPD?
With the Paxlovid.
COPD is a terrible disease. COPD is a respiratory disease that is going to get people into trouble. And absolutely, these are the people that should be on Paxlovid. Asthma is a different disease and certainly affects different age groups differently. So it would depend on the whole history and the age of the patient. But COPD, without question, COPD increases mortality dramatically. So yes, I would want to cover those people.
Thank you.
Yes.
Thank you for an amazing talk. I just want to go back to the CDC with the RSV. I know NACI might take a little bit of time to have those recommendations. And CDC talks about shared decision making. I just wonder, I mean, it's a fair comment about insurance, but I still wonder, is there any, I haven't seen any data from the hospitalization perspective. So I just wonder, are we waiting for a little bit more data for stronger recommendations?
So I don't think we are. What we don't know yet is how this is going to impact the general population, because the vaccine was just approved in August. But this is RSV season. And what we saw last season with no vaccine was a huge amount of hospitalizations and concomitant death. So my own feeling is the vaccine will protect you for 2 seasons, this season and next season. We're not sure about the 3rd season because the study group is still being evaluated. They're in their 3rd season and you're in your 1st season. So we'll know whether it protects you for the 3rd season. But what we're hoping to see in the next 2 years or so is some public health data on a drop in admissions to the hospital. We have an aging population. We have a population that has multiple comorbidities. And if I see an 80-year-old or a 70-year-old with comorbidities, I don't want to wait and take a chance that we're not going to immunize you now. We're going to wait 2 years till we get more data. I want to keep you out of hospital this year now.
So don't misunderstand me. Of course, we should be vaccinating them. I'm just wondering why it's not as strong of a recommendation yet. And if it's the lack or us not seeing the evidence.
Yeah.
I guess that's the research side of me asking that question.
I'm sure there'll be more evidence coming, but my understanding was it was a very carefully worded statement because they have many different interest groups that they have to account to. And importantly, in the US, not to go off topic, But the RSV vaccine from Pfizer is being used for maternal use. It's being used in your third trimester between, I think it's 32 and 36 weeks, so that we're protecting babies by immunizing the mother. So these are very safe vaccines that I think are going to be very widely used in the near future.
Can I ask a second question?
Sure.
It'll be quick, but I think the audience would probably like to know this. When you're sitting with your patient knowing, and I totally understand the perception that we give that patients can't afford it as to what they want. I guess my question to you is, how do you approach your patient between the Prevnar that, at least in Ontario, they have to pay for, and the RSV if you have to, you have to pick? How do you approach that?
So that's a very good question, and it partly depends on the patient's age, and it partly depends on what they've already had. So if they had Pneumovax a few years ago, or they took PCV13 even 5-6 years ago, I'm going to tell them for this season, take RSV and come back and take PCV20 when they're able. If they've had no pneumococcal vaccine whatsoever, I'm most likely going to go with pneumococcal vaccine as my first choice. But it's like Sophie's Choice, right? You remember that book? It's like you don't want to make that choice. And what I suggest to people, and with all due respect to everybody's financial situation, I talk about the fact that there is a cost for vaccine. I'm not denying that, but there's a cost for not being vaccinated. And when you take the cost of not being vaccinated, you're a little bit playing Russian roulette with your health. And in fact, when we're seeing the numbers increasing with COVID, and you get in hospital with COVID, or a hospital or a long-term care outbreak with COVID, you start to see more of these other diseases. And so I think it's a difficult decision, but it depends on if they've ever had a pneumococcal vaccine or the situation.
Thank you.
Hi, my question is about Paxlovid. What I'm noticing is a lot of the patients who are high risk for COVID, and then when it comes down to taking the Paxlovid, they're actually declining the Paxlovid because of the medications that they're on, and they don't want to stop their cholesterol pill or their high blood pressure pill or their blood thinners. So the question for me is, do you hands down always make those other med adjustments so that they can take the Paxlovid? And how do I, it's like convincing them.
So first of all, stopping a statin medication for 5 days is no big deal.
Yeah.
You know, you can stop Crestor, Lipitor, whatever you're on for 5 days. It's not going to impact your long-term cardiovascular risk. That's the easy one. In terms of the anticoagulants, it depends what they're on, because some interfere and some don't. And so I generally would switch anticoagulants if they have atrial fibrillation, because I don't want to stop an anticoagulant. So I'm going to do this with the pharmacist, and it depends on the risk of the patient. Excuse me, I recently had a patient who has stable heart disease, stable diabetes, well-treated depression, got COVID and got very anxious about having COVID. And that's exactly what we did. We stopped the statin. We stopped one of the urologic medications that interferes as well. You're only on Paxlovid for 5 days. It's a very short course. I'm told it tastes terrible. I haven't had it myself. You take 3 pills in the morning and 3 pills in the evening, and it comes in a package. So it's just push out the pills. It's easy to keep track of. If you do have reduced renal function, it's 2 and 2, not 3 and 3. But basically, it's only a 5-day course. So I don't want to find out 10 days later that they're that sick and now in hospital when I could have given them Paxlovid right at the beginning.
So always push for the Paxlovid then.
I'm sorry?
Always push for the Paxlovid then.
In the appropriate patient who's got comorbidities, yes, because, you know, if they're 25 and they're healthy, I'm not worried that they're going to end up hospitalized. But in a patient with COPD, you know, COVID and COPD is a bad combination. These are the people that get very ill. So yes, I'm in Ontario. There's no there's no hard and fast rule in terms of age and risk. It's partly physician decision. And so I'm looking at the comorbidities in people.
Thank you.
Thank you. I also speak with the pharmacist, because the pharmacists are my best friend. And truthfully, and I don't know if there's pharmacists in the audience, so this is not a plug for pharmacy, but in my office, we share the waiting room with a small pharmacy. And we talk all day long about different drugs and drug interactions, and that conversation is often very helpful. So the pharmacist will often review these medications for me or with me when I'm looking at Paxlovid. Yes, any other questions?
There's one more online, and it's actually specific to RSV. And the question is, if you've been exposed to RSV, say through a relative, how long should you first consider getting vaccinated, and how long should you wait?
So even if you have RSV, it doesn't give you long-term immunity. It gives you very short-lived immunity. So you can get RSV over and over again as a healthy adult, as a healthy child. Most of us did have RSV as children, and that doesn't mean we're well protected. So if you've been exposed to RSV, the contagious period is about 7 to 8 days. If you're more than a week since you were exposed and you don't have it, then I would take the vaccine.
If you do get it, how long should you wait?
I'm sorry?
If you do happen to develop symptoms, how long should you wait?
So there's no clear rule on that. I would say if you do develop symptoms, you want to wait until you're perfectly well. So I'd give it a month or two. But again, you're not protected against another episode. That's personal opinion. There's no guideline on that. Yes.
Thank you very much for all the information. I'm glad it's being taped so I can watch it again. I don't retain a lot. I'm curious about the COVID information that you shared at the beginning and the list of individuals who are more at risk. And disabilities was on the list, and ADHD and developmental disability. And I wonder if you could speak to that, because I found that really curious, because I was looking to see if it would come up, because you highlighted, watch and look at the list. And it didn't come up. It just came up with COVID. Can you comment on that?
It's very interesting. It's an association. I don't know that it's a cause and effect. And this is some of the data that we're keeping in Canada. And when we talk about someone with disabilities, what is their ability to get vaccinated? What is their ability to be active in the community? What is their disability exactly? So these are big numbers and they're an association, but I don't think it's cause and effect. So I can't really answer that question. I think it's a good question. And people are looking at different subgroups as being more at risk. I don't know if you remember, but when COVID first started, there was great concern about the northern communities. And the northern communities did not do well. And was that because they didn't have the same level of healthcare? Was it because they didn't have the same access to vaccine? If anything, we gave them vaccine first. But there were a large number of people that opted out of vaccine because of distrust of the health system and the whole worry about whether we were testing the northern communities with the vaccine before we were giving it to southern communities, a lot of distrust about healthcare. So it's hard to know what are the major factors when we look at different groups that have done poorly. But just in general, those groups do poorly. So I don't know the reason.
Yeah, because I really wondered if it had to do with group a lot of times. Well, in northern communities, there's congregate living, like multi-generational families.
Yeah.
But also with the group that we're looking at, often they're living in some group settings as
group
well.
homes.
So I'm wondering if some of that, but thank you very much.
I'm sure that has something to do with it. And again, I don't think it's cause and effect. It's an association.
Yeah, thanks.
Thank you. So I'm just going to say thank you to this audience. You do incredible work. And I think you're seeing patients that are vulnerable, for a lack of a better word. And it's your work with them that's keeping them healthy. Because if they don't have the attention and the care, all the doctors in the world can't do that kind of support the way you do. So thank you for the work you do, and thank you for being with me this morning.
Thank you, Dr. Brown. That was amazing. I think we could listen to for another hour and lots of questions. I know you got a lot in there. And I really want to thank our sponsor for the program today, Pfizer. Pfizer has always been a company that has really supported the work of the respiratory educators. You might notice the other company isn't here, and it's not that I haven't asked. So thank you very much to Pfizer. And we're going to take a very, very short bio break. It was about 5 minutes, and then Dr. Keys is going to start, and we're going to spend the morning really for you to spend time on self-care. This is all about you this morning, so really looking forward to that. So 5 minutes.